Professor Amanda Howe. I'm from the UK. I work in a medical school there. I'm also President-elect of the World Organization of Family Doctors. Okay, well, I'd like to add my thanks to those who've invited me to be here. And I must say I would also like to thank the American immigration authorities for finally letting me get through and even get through Atlanta with 2 minutes to board the plane. So great to be here. You've taught me something about my determination and resilience. And actually that's the commitment, because it looks such a great program. I'm really honored to be here. And please do use me as a resource. Your guys have worked very hard to help me to get here. And so I want to give the time to you while I'm here. Apart from lunch and people being tired, the other loss of being in the afternoon is that some great stuff that I was going to say has already been said. But hopefully that will triangulate, that will validate, and you'll find some common messages. Claire in particular and Shannon started with patient perspective, and I think that's the right place to start too. So I'm speaking here to you as a family doctor, and as an academic, and as some sort of a leader in my time. Let's go with family medicine first. Busy clinic, next patient, looking who she is. Leanne Davis, mixed race, 16, just a kid. Call her name, tall, thin, smart style, short dress. Walk her to the room, angry, anxious, looks distressed. Hi, Leanne, I'm Amanda. How can I help you? You know my mum, she says. Cue, my eyelid flickers. Why start there? She sees, she stalls, then speaks. She said you'd help, but I don't think you can. And then the story starts of drugs and men and sex, a young woman with few life chances about to lose the rest. Is she pregnant? Is she safe? What really matters here? I ask, she weeps, and pretty soon we've got a plan that's clear. I'm running late, we haven't done the BP or the checks or vaccines, contraception, swabs, but these can wait. The test is that she stands and smiles and says, my mum was right, thanks, Doc. I see her out, and I think she'll take the steps to make it through. And we've agreed to meet again to do those tests and see whether she's safe and made a turn in her personal history. So measure that. I think we can. But when you give your mark, it is the professional love of Leanne should take the highest part. So that's not a romantic notion, actually. As we've heard earlier, there's plenty of evidence that if Leanne gets a better start in life, she'll be healthier for longer. Her kids will do better if she chooses to have any, choice being an operative thing in that, and will have played a part, just one of the parts that family doctors and communities can play in ameliorating the social determinants of health. And that's not easy. You have to combine skill. You have to know, for example, how to establish really good, trusting interpersonal skills very quickly, how to help people disclose really difficult stuff like violence and addiction. And that's not an easy job, and you have to know how to enable people. So it's not romantic, it may be a passion, but it's also very evidence-based. So my big idea is, and as I say, it's been echoed already, let's value, measure, and reward good professional clinicians and services who can help the Leannes of this world and other complex patients, so that means clinically complex with multiple medical problems, as well as socially complex, to do better for longer and to intervene earlier. That's a credible idea because professionalism can be judged by doing what's right. It's scalable because you can see how it goes up over time if you watch it correctly, and it's a counterintuitive idea because, frankly, money is not going to be the primary motivator to get it right with that patient. So you've asked me to talk about the UK experience. I'm looking back a dozen years or so to 2004, when the quality outcomes framework came in, and that was meant to make those of us working in primary healthcare deliver better care to more people so that the overall cost of healthcare went down because people wouldn't get so sick. And the idea that adding some income that rewarded me to do the right things for my patients felt good, because frankly, if I'm already doing a good job, I'll get more money for doing it, and other doctors, perhaps who haven't quite raised their game, will probably get better. So looking back, that looked like a good idea at the time. And in fact, the QOF, as we call it, changed quite a lot of things. Particularly, we started to organize care much more around health checks, prevention, health promotion, early screening, and around the follow-up of chronic illnesses such as diabetes. We firmed up our electronic records to record and retrieve the data that was needed, both to do that kind of population-level work, to keep follow-up with people, and to get the payments, to be fair. And we shifted staff expertise around a bit so that we saw primary care teams grow in the UK, and in fact, they hit the targets ahead of where the government expected. Good so far. But the downside was that it did gradually bias overall where we put our energy and time. And I'm absolutely confident that most of my colleagues did continue to do the professional thing and do it properly, you know, the acute care, the diagnostics, the support. But the QOF somewhat dominated our thinking, and it dominated the way the team built up and the way we used their skills. And looking back, as a family doctor, I think it did risk being too patient-centered. So you could work around that, and as a professional, I often did, but it still held us in our meetings, in our huddles, talking about the points and the protocols. And for some people, they felt it was skewing the consultation. You know, you get these pop-ups. You open the record, and instead of reading Leanne, you know, how old she is, what her background is, you've got, have you screened this patient for X or atrial fibrillation? And it just kind of isn't the way we teach the residents to open a consultation. So definitely some risks there. And then patients started saying, oh, I've been for the diabetic check, and then I've been for my asthma check, and I've had my medication review, but do you know, I wanted to go to my bridge club this week. And it feels like people used to say about hospital, about ambulatory care, you're going to all these different clinics, couldn't they all do stuff at the same time? So it was getting less integrated, and of course, against every consultation, you've got time and you've got workload. More money came in against the QOF into the system, but most of it went out again into additional IT, additional administrative time, and additional clinician time. So I don't think we made much money out of it, and it certainly didn't help practices like mine focus on the Leannes of this world. And people also have said to me when I've discussed it, it felt unprofessional, especially when indicators started to come in that didn't seem evidence-based at all. With my academic hat on, I've put a briefing in your packs or whenever you get them on the website, but a quick summary of the evidence does show that the QOF did improve performance against the indicators in the first phase. It did reduce variation between practices, and it definitely increased population coverage, but that was mainly in the areas that were incentivized. There's no evidence that stuff that wasn't incentivized dropped off, but it didn't go up at the same rate. And standards were pretty high already, so actually the added value was unclear. I don't think our government had really looked into the black box of primary care to know where the baseline was before this started. And there was a lot else going on. So my colleague Martin Rowan says it's the context, stupid. You know, there was other stuff going on that was uplifting quality. And so QOF, whatever QOF did, it wasn't standing alone. And then I guess what my colleague in family medicine just said, you know, it did lose credibility over time because there were more political drivers. People started saying, oh, we need the GPs to do this. Let's incentivize that. And there was more lobbying, and stuff came in that actually people felt wasn't really evidence-based at all, and that felt deprofessionalizing as well. I think the point's already been made that also quality outcomes framework would have worked differently in another payment system. So you know in the UK, we don't change money with the patients when they're in front of us. It's a taxation-based payment. We're paid by capitation, provision, and quality initiatives. But actually, I guess if you were changing money, it could work completely differently. So that's a really important discussion for this forum. And if I put my national hat on, I'd say these are my suggestions to you. The money, if you're going to put extra money into the system to come to primary care, excellent. It's got to go into the stuff that patients need. Otherwise, you'll get the same problem as we've got in the UK, people saying, I'm a professional, this isn't evidence-based, it's driven by politics or it's driven by commercial lobbying on your bike. Yeah? It's got to be enough money to compensate for the added work, including the recording and the reporting and the staff time and all that. It's got to reach the people who need it, the people who aren't getting the full package of care already. So if you pay doctors to do more with the people who are already coming to the office, you know, that may be great for that doctor, but it may not be value for money for the system or for the patients. So is everybody going to get this offer? And this still puzzles me about how you're going to do that here, because we've got population coverage. I don't know how it's going to work here. But if that guy going past the window, who's got a family history of diabetes and is really plump and is in the right age range and is a smoker, is not getting somebody calling him in to have the check, to have the conversation, to see if he's at risk and willing to take any advice about it, the whole thing's going to fall on its feet because you're not reaching the people who really need the help. The next thing I'd say is make the measures global. So at one point we had 138 indicators. I'm sorry, Shannon's had to go. She was talking about 9 or 21. We had 138 at one point, and that is much too much micromanagement. So you've got people in front of you. You know, if you have to say, could you please fill in these 3 questionnaires for my payment before you go? You know, that's not going to keep the Leannes in the room. It's not going to encourage her to talk to the doctor in the way she needs to. And she's going to wonder where we're at. So you get my point. So robust global indicators at a higher level, as high as you can get them that are valid, is going to be much better for your time and actually for the system. And then the other thing is that really the QOF didn't follow the most needy patients. So it neither followed my lovely elders in the nursing home who had at least 170 indicators each by the time they were in there. So, you know, actually that money where our government have incentivized us to work with nursing home residents has had to come through another route. It didn't at all go into community outreach, so there was no money pitched against doing the kind of collaborative work that we were talking about following Claire's paper. I was in a summit for Ibero-America in Costa Rica before I came here, and a colleague from Uruguay said, a family medicine colleague said, well, I get 10 hours a week to do community partnership work. And sometimes that's a government agenda, sometimes it's local to our communities, sometimes it's people coming to us and asking for things that the community would like to know about. That's in her job plan. In our QOF system, nobody put money against that kind of work. So the excellent equivalents of Iora Health in my country, Bromley by Bow, were just doing it out of love. And that's not going to change the whole system. The innovators may do it, but it won't uplift the rest. So I think the discussion we had about quality pitches being partly about giving time and energy to the collaboratives is very important too. So what kind of measures will, I mean, I'm hoping the US can do better than the UK, but there are an awful lot of factors to consider. I'd just like to end with a couple of slides to summarize that. And you've asked me to talk about measurements, so I tried to think, you know, so what would we have to measure to really know how quality was going for this bigger picture? I've told you the QOF did these things. It wasn't so good at those things. My colleague Michael Kidd, who is president of WONCA, has been involved with the Primary Healthcare Performance Initiative, which is going on at the moment with Gates Foundation. And I adapted this slide from one that he gave recently, we were trying to think, so if you wanted to be really community-centered or really person-centered, maybe you should be measuring, where's the clinic? How accessible is it? Not just physical accessibility, distance, but also, linguistic, culturally. Taking patient feedback, we've had a good try at that with QOF. We've had some big surveys and had to take those on. That was incentivized in the QOF. Again, people can be cynical about it, but actually the patients get it. They want to give feedback, and it has changed the culture a bit. People are beginning to come and tell us stuff. We have patient groups now who, in more practices than we used to have, who give us that voice of the consumer and try and have a direct dialogue with us. Questions about outreach and community needs, and then actually rewarding continuity of care. Now, that's a complex issue, but we can discuss that more maybe in the groups. I'm getting the red card, so I should need to pull it together. Integration, how good are we at integrating stuff, including mental health? Can we measure that? Can we reward and incentivize that? Are we doing the upstream stuff, the health promotion, the prevention, the screening? Measures of quality and safety, that matters too. I've just put 2 examples, but there are hundreds that we could be having a conversation about, and that is about good quality of care. And most of all, I think personal and community engagement. So will payment reward the care of these people? That's what I'd really like to know. Thank you very much.